Healthcare reforms implemented in the last 15 to 20 years have resulted in some tangible and positive results, the most significant being an improved life expectancy up to 60 years. However, there's still some major challenges ahead, and one of these is the spiraling cost of healthcare delivery. This is especially so in the private health sector that only serves less than 20% of the population and yet consumes over 50% of the total healthcare expenditure. So the most pressing healthcare challenge is how to lower costs across the value chain while improving healthcare outcomes. Can this be achievable? Well, that's a question we'll try and answer in today's program. We have a panel of important stakeholders from civil society, medical schemes, hospitals, and medical professionals who will help us answer this question. So sit back, relax, and enjoy this exciting show ahead. Interact with us on our Facebook page, SABC Health Talk, and on Twitter at SABC Health Talk, including our email address, healthtalk@sabc.co.za. I'm Dr. Sello Mutaung, and this is Health Talk.
Healthcare doesn't come cheap in South Africa, and the quality of care depends on affordability. State facilities are free to those who are unemployed, but most of these facilities lack sufficient equipment. They are badly managed and some of them are overcrowded. As far as health is concerned, this is a global problem. These problems include rising costs and poor access to generic medication, an overemphasis on cure instead of prevention, and lacking governance control. Mark Haywood, who is the Executive Director of Section 27, a public interest NGO that promotes human rights, also believes that the cost of health is expensive.
I do think it's too expensive, and I'm not alone in thinking it's too expensive. I think that anybody who has the privilege, in inverted commas, of access to the private healthcare system feels that to some extent the services they receive are disproportionate. Excessive. I mean, the costs of the services are disproportionate and excessive, and that despite the protection that things like medical aid schemes are meant to give you, you end up significantly poorer whenever you access private healthcare.
Regulation in private healthcare had two surfaces, one being medical aid scheme and the healthcare providers.
You know, for some people, the cost of private healthcare can be catastrophic. Particularly if you're not insured. If you end up having to spend a week or 2 weeks in a private hospital, it can cost literally hundreds of thousands of rands.
The proposed National Health Insurance System sought to rectify this, in line with citizens' right to access affordable, good quality healthcare irrespective of their social economic status. It is acknowledged that although there are unique experts to improving health in South Africa, the local challenges represent a microcosm of impediments to improving population health globally.
In presenting the 2015-2016 budget policy statement at the Department of Health, the National Health Minister, Dr. Aaron Motsoaledi, stated that the budget policy statement shall be fully informed by the National Development Plan, or the NDP. Now, the NDP envisages that, among others, life expectancy in South Africa will have improved to 70 years by the year 2030. The question is, however, is our healthcare system geared towards ensuring that the noble ideals of the NDP can be achieved by 2030? Well, let's find out from our special guests. In Johannesburg, we have Sasha Stevenson, who's attorney at Section 27, and we also have Dr. Dumisani Bomela, who's the CEO of the Hospital Association of South Africa. And in our Durban studio, we have Professor Morgan Chetty. Professor Morgan Chetty is the chairman of the KwaZulu-Natal MCC and the IPA Foundation. Gentlemen and lady, welcome to Health Talk.
Thank you.
Welcome. Perhaps let's start with you, Sasha. I mean, we're talking primarily about cost of healthcare in this program. But let's start off by looking at, in general, I mean, what are the major health challenges facing the country currently?
Well, firstly, we should note that we talk about the cost of healthcare in the private sector, but the Constitution says we have one healthcare system. We have a unitary system. And so what happens in one system affects the other system. But in South Africa, generally, we have some serious health challenges. We have a high burden of disease with HIV, TB, non-communicable diseases. We've got a public healthcare system that is severely strained, that sees 87% of the population with less than 50% of the doctors and with insufficient funding. And we have a private healthcare system that sees a small portion of the population, provides generally good services, but is beyond the financial capabilities of most people. So we have a number of problems. We have burden of disease problems, and we also have inequality problems. And those are some, I think, of the key challenges that we're seeing.
Dr. Pamela, from your perspective, I mean, which are the major ones? I mean, she's listed quite a number of them. Which are the major problems that should be priority areas, in healthcare in this country?
So she's highlighted two parts of our system, the private and the public sector. Now, one of the things that have made the problem that's already been stated worse is the fact that there is fragmentation between these two systems. Yeah. Where the private sector can do more, there's more that the private sector can do. If the work was able to come through. And on the other side, the public sector is overburdened and finds it difficult to cope. And we have to find a way of bringing these systems to work together so that then there is some synergy which is lacking at the moment. Okay. So most of the problems that we see are in fact global phenomena and are not unique to South Africa. Right. And over and above what's already been stated, I think it's important to note that we need to take a few steps back and look at the entire structure and see what are the things in the architecture of our health system as it is at the moment that are causing inefficiencies which are driving these healthcare costs up.
Well, what are those things then?
So if you look, firstly, I'll look at the private healthcare environment. If you look at the way that the fragmentation occurs within that environment, and it's because of the way that the regulation allows it. The system can function as much as the regulation allows, the enabling regulation. Yeah. So you have various pieces of regulations. The Medical Schemes Act, it's discouraging primary health care in the way it's structured.
Well, you talk about regulation. We have an attorney in the House. Your view on regulatory matters insofar as, healthcare challenges, whether or not they're enablers or in fact they're impediments?
I think the first thing to consider is the fact that the Constitutional Court has said that the government is entitled to regulate the private health sector. They said that in a case a long time ago. And we're now starting to see the outcomes of that. There is some regulation of the health sector. There's, for example, the private health sector. For example, there's the requirement that medical schemes pay for certain prescribed minimum benefits. Those are basic conditions that are often expensive, that medical schemes are required to pay for without co-payment and without requiring payment from the user. And we're seeing some problems with compliance with those regulations and enforcement with those regulations. So those are just some of the regulatory challenges. And I'm sure as one of the issues that the market inquiry into private healthcare is going to be looking at. What is the role of the regulator? What is the role of the private sector? And what is the role of government in ensuring access to healthcare services for all? Okay,
I'll come back and ask you a question about, the rationale behind, that inquiry now. But for now, let's just cross over to Durban and invite comment from Professor Chetty. Professor Chetty, your view, please, in terms of what the major healthcare challenges in South Africa are today.
Thanks. I think a lot of these have been covered by the first two speakers. So I want to talk about two things. One is I want to take up the point that you spoke earlier on, mentioning that one of the intentions is to try and increase the life expectancy, the age of 70. But that comes with a number of prices that we're going to realize. The first important price is that it's internationally recognized that if you increase the life expectancy to 70, you actually find that in the latter part of people's lives, 30% of your healthcare resources are spent on 5% of the people. And the reason why you spend that kind of resource is that people have more comorbidities, they have more hospitalizations, there are new modalities of care that are required, longer hospital stays. So I think we're going to be very careful when we prepare to enhance life expectancy, that we have all the finances in place, the facilities in place, because we're actually getting a cohort of patients that are going to cost the health system 30% of the healthcare spend. But I want to go back to what I think is a big issue. And I think the big issue for me is that for too long, the patient, who is the most important resource that we have, is left out of the equation looking for solutions. And I want to discuss this in three ways. One is the drivers of healthcare cost. I think if you look at the demand side in healthcare costs, you'll find that this refers to the behavior of recipients of healthcare and what they do. And the first thing we spoke about, the aging population and the demands of that.
Okay.
We also find that patients...
Prof. Chetty, I'm so sorry to interrupt you, but I want us to come back to the drivers of healthcare, perhaps in the next segment. But for now, I just want us to take a quick commercial break, and we'll be back with you just now. When we return, we'll look at healthcare funding in South Africa. Please stay with us.
Culture is most definitely defined through one's individual style, be it through music, lifestyle, and fashion. Live Magazine has been in existence since 2010. It is a youth-run media channel covering a range of topics from fashion, politics.
We need, and there's a huge gap in South Africa, skilled museum personnel, such as collections manager, restorers. That is a gap.
Pattern of contact includes the 14th century Chinese world map. This is one of the oldest surviving world maps, titled Da Ming Hun Yi Tu.
Join Musam Khalipi on Afro Showbiz every Saturday at 19:30 CAT.
Morning is when different people take different directions to different places for different reasons, to do different things. Streets come alive. Evening is when people go home to their loved ones and turn to South Africa's most watched and trusted evening news. Because we keep the nation fully informed. We are SABC News.
Engulfed in crises. That's how the United Front sees South Africa.
This South Africa is not one of our dreams. It is not the country we deserve and demand. This South Africa is not meeting the needs of its young people.
Well, President Jacob Zuma said Eskom's woes are a challenge but not a crisis.
We have a plan to deal with the matter, and it's a good plan. When we can say we have a crisis, now we have a challenge and we've got a solution.
That's Business News, weekdays at 6 p.m. on SABC News.
Welcome back. Now, the national healthcare budget presented by the Department of Health grew by 7.4% from 2014 to 2015. On the other hand, medical aid contributions grew by an average of 9.3% for the same period. Yet the Consumer Price Index, or CPI, as at the end of 2014 was 5.8% and is expected to in fact be even lower in 2015. So how exactly is healthcare funded in South Africa? Let's understand this from our guests. In our Johannesburg studio, we're now joined by Dr. Mike Marshall. Dr. Mike Marshall is the Senior Manager on contracting in private healthcare at MedScheme. Welcome to Health Talk.
Thank you. Thank you.
And of course, we still have Sasha Stevenson from Section 27. And from our Devon studios, we still have Professor Morgan Shetty, who is a family medicine specialist. Now, Sasha, if I could start with you. I mean, you know, we spoke a little earlier about the whole notion of budgets, by the Department of Health, and we've seen that over the years, the budget has increased. Of course, there's something positive we can talk about in terms of, some of the successes over the years that we now have an improved life expectancy, amongst others. Okay. Now, can we just understand from you just how budgeting works in terms of healthcare?
How long do we have? It's a complicated matter.
Right.
Firstly, there are national and provincial budgets. So the National Department of Health gets allocated a certain amount of funds. Some of that goes to provinces, some of it goes to the National Department of Health. And secondly, from the provincial equitable shares, different provinces allocate different amounts of money to healthcare and other services. And so you have quite significant inequalities in the amount of money being spent per patient in the public healthcare, at least, in different provinces. I think
what does that mean?
So if you look at the numbers, the National Development Plan suggests that in the Northern Cape, the least amount of money is spent per patient. It's around 900 and something rand a year. In the Northwest Province, on the other hand, 5,700 rand is spent per patient. So there's a huge inequality between what different provinces spend per patient. And that's not necessarily a bad thing. It depends on distances travelled, access to primary healthcare services and that sort of thing. But there's significant inequalities just within the public healthcare system. Mm-hmm. Then when you bring the private healthcare system into account, those inequalities obviously become much wider.
Yeah.
And we see, for example, in total, 8.7% of GDP is spent on health in South Africa. That's the same as most high-income countries. Right. Half of that is spent in the public sector, half of that spent in the private sector. The private sector is serving a much smaller percentage of the population. So you can see immediately where the inequality comes in.
And of course, the source of the funding comes from you and I, the taxpayer.
Yes.
Any other source of funding that donor funds, for instance?
Donor funding makes up a very small proportion of healthcare funding, so it's about 0.2% of GDP in the form of donor funding. But donors have an important role to play, particularly in key programs like HIV and TB. Right. Donors have historically played a very important role.
Yeah. Okay. Dr. Marshall, we've spoken earlier about the private health sector, but before I come to funding in the private sector, let's just understand. I introduce you as somebody from MedScheme. A lot of people out there don't quite understand the difference or appreciate the difference between a medical aid or medical scheme and a medical aid administrator. Can you perhaps just clarify us on the difference, please?
Sure, Sela. I think that's a very important differentiation. So a medical fund or medical scheme, as we know it, is really a vehicle to collect members' contributions and to pay claims. It's a funding vehicle. It's not a for-profit entity, and I think that's very important to understand. So if the funds that are left over, so-called the surplus in that, are for the members. The funds belong to the members, either to go back to the members in terms of lowering their contributions or alternatively providing more medical services.
Right.
However, those entities require someone to service them. So they require someone to collect the contributions and to pay the claims. But they also require someone to manage the costs. Right. So that's the so-called managed care. So most, not all, but most funds outsource those activities to to corporate entities that do that. Now, those corporate entities are for-profit entities. Some of them are listed on the stock exchange. So you've got this dynamic where you've got this sort of non-profit entity for the benefit of members working in parallel with corporate entities which provide administration and managed care services which are for-profit.
Right. Okay, all right. That's an important one to clarify. But at this stage, let's go over to Devon studio and speak to Professor Chetty. Professor Chetty, in terms of, we've understood from Sasha, how healthcare funding works, in the public sector, in government, as it were. How does it work in the private sector?
I think in private sector, it's run very much on a commercial basis. It's based on, it's funded by contributions that the patients make to a medical scheme. As Mike just explained to you, that those funds are put into a fund, and that fund is then managed by an administrator. The important point is that when you do it in the private sector and it's done through registered medical schemes, registered with the Council of Medical Scheme, then there is a little bit of a reliability to the way it's done, in the sense that those funds are then guaranteed by the Council of Medical Scheme having certain rules and regulations, and there's a solvency fund put into place which guarantees the patient that if he engages the healthcare system, incurs a cost, those costs will be met. So basically it is funded by the patient, managed by the medical schemes and the administrators, and it is subsidized by the employer, not all the time. Some is self-funded, but there also is a government subsidy towards the contribution. So that's basically how it's done in the private sector.
Okay. Then we hear of the so-called other insurance products or gap products and what have you. What role do these play in the industry?
I think they're getting bigger and bigger and bigger, and these are insurance products registered with the Financial Services Board. They're not registered and they're not endorsed by the Council of Medical Schemes. Now, the problem we have with these contributions and this kind of funding is that it is a funding that so far has been done because it's very entrepreneurial. A lot of people are involved in it, and what we've been seeing is that a number of the small Financial Services Board approved funds in terms of insurance products have never really stayed the length of stay. With the result, there is no guarantee that the patient has recourse to go to in order to get his bills serviced. And we have a number of incidences in which funds have gone insolvent and the patient was left with a huge debt. So until we get some sort of guarantee from the Financial Services Board, like the Council of Medical Scheme does, we're going to find that this is a little bit more risk-based than the traditional medical schemes that are registered with the Council of Medical Schemes. Okay.
Sasha, before I let you go, Prof. Chetty mentioned something about medical aids required to have some sort of reserved by, in terms of the Council for Medical Schemes regulations. Mm-hmm. Now, when it comes to the issue of access, what's your view in terms of this requirement for medical aids to have reserves versus the possibility that if these reserves are either lowered or done away with or something, that it'll improve access, it'll enable a lot more people to afford medical aid? Your view?
I'm not sure that it would necessarily improve access. The point of the reserves is that medical schemes are stable, and that if something happens and that if a lot of their members need to call on them for assistance, they have that protection. And I think that there's more of a risk to the user of healthcare services if a scheme doesn't have sufficient reserves compared to if it does. Mm-hmm. It's more of an access issue for a medical scheme that isn't sufficiently stable and wouldn't be able to pay out all claims if needed to. So I'm not sure that that's necessarily a limitation on access.
Okay, all right, okay. I'll ask for your view a little later after the break, because unfortunately we've run out of time, and I know that you want to really contribute on this. Let me just take this opportunity and thank you very much for your contribution, Sasha.
Thank you.
All right, we're going for a quick commercial break. And so what is it that drives healthcare costs to levels beyond inflation rate? We'll find out after the break. Please stay with us.
Did you know that in every South African election over the past 20 years, women have outnumbered men in voting? How cool is that? Big up, ladies. You rock. So get registered and keep the girl power going.
Are South Africans going to play the lotto come June the 1st?
I just want to ask a question. It might sound foolish. Now, I've never met one person who told me she has won or he has won lotto. I've played lotto throughout. I've never won. Is it true or is it fake?
The definition of lotto is a game of chance. Many people who shake my hand, sometimes they say we don't have to wash because maybe the numbers are in my hand. I don't know them.
Watch Question Time with me, Mpho Tsedu, Monday to Thursday at 5:30 p.m. on the SABC News Channel.
Sparks fly over Verwoerd. Let's now have a look at this. Now, Verwoerd, the comment yesterday in Njanji, Mr. Sparks lived up to his name and caused quite a few sparks.
It was quite shocking for me to hear him compare H.F. Verwoerd to Helen Zille in terms of her orator skills.
Mugabe to compensate white farmers for land grab.
I don't know if I'm justified to call it truth and reconciliation Mugabe style.
Watch Media Monitor with me, Alicia Jali, Sundays at 9 a.m. only on the SABC News Channel.
Technology is all around us and is improving lives across Africa, like how young Nigerians are connecting to the internet. There are doctors finding new ways to save lives in Cameroon, and the South African public transport system that is now getting Wi-Fi. We have gadgets, apps and loads more, some of which play a big role in Africa's growth.
A huge part of this African growth is technological innovation. To find out a bit more about social media and technology news from here in Africa and abroad, join me, Phumelele Zondi, every Sunday at 7:30 p.m. on SABC News.
Welcome back to Health Talk. So what exactly is responsible for the persistently high healthcare costs? Is it that the doctors get paid more and more for each consultation? Or is it that the cost of medicine are going higher and higher, or the cost of hospitalization, or the medical aids and the administrators are costing more and more? Well, let's put these questions to our stakeholders. We're joined back by Dr. Dumisani Bomela, CEO of the Hospital Association of South Africa. Let me be direct, Dr. Bomela, and ask you, what is driving healthcare costs in this country?
What we've seen in the past decade or so, but in the past, which has now been collaborated by some empirical research that has come out over the past few years, is mainly utilization. Now, when we talk about utilization, I think we have to refer first to what the minister has been saying about the quadruple disease burden that is facing the country.
Yeah.
And because that has now been seen right across the system, and what we've seen in the private hospital environment is that there's more usage of the services, and the patients are staying in hospital for longer, and the type of patient that is admitted is sicker. On top of that, there is a greater percentage of older patients over 65 that are being admitted. Now, if you look at all these four, each one is actually causing more expenditure and more intensity of treatment. And all those, they combine together And we've seen, and the research that has been conducted, it showed the trends from 2006 to the year 2010, 2012, to that period. And there was this consistent rise. So when we talk of healthcare costs, it is the money that the scheme has to pay to the service provider. And these are the problems that are faced by the service provider, so that ultimately it translates to the scheme having to pay more because of these factors that are encountered.
Okay, talk about the scheme paying more. Perhaps let's get a view from the medical schemes. What are driving the cost? What are you paying more?
Yeah. Sela, I think Dumisani has touched on the demand side factors, which is very important. The rising burden of chronic disease, hypertension, diabetes, and so I'm not going to touch on that. But I think we also need to look at the supply side and what's happening there in terms of, for example, care coordination. Yeah. You know, is care being properly coordinated between the GP, the specialist, and the service providers out there, or is it fragmented and inefficient? And we are finding that that is the case. So the structures and the way healthcare is delivered in that environment, you know, does certainly account for a lot of the wastage. But I think what's also very important to touch on is the legislative framework in which the private healthcare system operates as well. So, as Dumisani earlier said, I mean, the output of any system is dependent on the framework in which it works. Now, you know, and it's a whole probably discussion in itself, but for example, if you look at the prescribed minimum benefits, you know, what is in that package, and are they
Perhaps
correct?
For the sake of our viewers, just to, you know, unpack this whole prescribed minimum benefit story. What is it?
Well, this is part of the sort of solidarity principle of the healthcare funding, which is a very good principle. And part of that is that the healthcare funders must fund a minimum package of benefits. So these are emergencies, there are certain diagnosis and treatment pairs, some chronic conditions, but most of these conditions are very much focused on expensive hospital admissions. And I think that's where the challenge comes through. So when these prescribed minimum benefits were tabled, the focus at that stage was very much on trying to prevent the private sector from dumping sick people into the state sector. And these were supposed to be reviewed every year. But I think people are questioning now two things. One, what should be in that package, and should it be much more primary care orientated to try and prevent the downstream costs? And secondly, the issue of payment at cost, because as you know, the medical aids must pay for the prescribed minimum benefits at cost, which is at invoice price. And that in itself has created problems.
Yeah, okay. All right, let's cross over to Durban. Prof. Chetsi, you know, we are often I suppose, labeled as being too hospice-centric. I mean, all of the expenditure that we've been talking about here is at secondary level, for instance, at hospitalization. Are we spending enough in primary care, or should we be spending a lot more in primary and preventative care, do you think?
I certainly think so. You know, I think if you look at historically what we've inherited a very, what I would call a dysfunctional and a very inflationary system of reimbursement. We'll discuss that a little later. But I think we basically are a third world country. We have a pocket of first world, a first world country and a first world economy that's there. That's where we're seeing the very high rating of the healthcare in this country is in the first world component in terms of facilities, etc. But the predominant requirement in this country is primary care. Now, if we go to the healthcare spend, and it may not be very accurate in terms of the percentage points, but of our healthcare spend, we are only spending 7% on primary care. And if that's the predominant entry mode for people in this country, then we're actually not spending enough. We're spending 20% on specialists, about 25 to 30% on medicines, and another 35% on hospitals. So certainly, it's theoretical. It's nice to say. It's said over and over again that primary care must be the entry point. The Minister of Health has made this very clear. But the actual proportion of healthcare budget spent here is very low. The second factor that's very important to say is that our healthcare system has been developed on the lines of us having to pay for volume of services rendered. The more service you render in the fee-for-service system, we pay for that. We're not paying for value and for outcomes of care. So I think the important thing is that we need to spend more money on primary care. We need to refocus from short-term gains to longitudinal outcomes, and we need to pay more to what I would call patient-centric healthcare versus a person-centric healthcare versus patient-centric. Our system is very patient-centric. We tend to react when the patient gets sick, but we do not have a program in place to keep the person healthy and the population healthy. So I think the focus in this country, besides paying more to doctors, is to refocus on preventive, promotive care, to refocus on the person and bring the person, the patient, into the equation to help control and manage costs.
Mm-hmm. Dr. Marshall, whilst one appreciates, and I think Dr. Bomela mentioned the issue of increased burden of disease and so on, but whilst one appreciates that, still the medical inflation far outstrips consumer price index. Why is that?
Well, again, I mean, in this country, medical inflation is probably sitting at about 4.1% above consumer price inflation. And again, I think the reasons have been mentioned. Again, the demand side issues, the chronic disease, the lack of care coordination, the legislative framework, and perhaps to touch on that again, we have a system of solidarity in the healthcare funding environment, which is a very good and was introduced, with the Medical Schemes Act. And what that says is that anyone can join a medical scheme. They're not restricted from joining. It's open enrollment, and there's what we call community rating. In other words, no matter how sick you are, you pay the same amount, which is a very good principle. But the problem that you have, Stella, is that for that risk pool to remain viable, you need to get young and healthy people joining. Now, in order for that to happen, you need to almost have a kind of mandatory membership. And we don't have that at the moment. Yeah. And the other thing that you need to have is you need to have a system whereby those funds that have sick and ill patients pay in what they call the risk equalisation fund. And that was something that happened, but it was sort of withdrawn. So we've got this we had this path of social health care and reform which got sort of halfway along the way and then stopped. So what's happening is the prices are going up because we're not getting younger, healthier people in there joining maybe some of the health insurance products and that, and so that's why the pool is getting sicker and sicker, and it's not growing, and the price is going up. So we need new, younger lives to get into the private healthcare market to make it sustainable.
All right. Okay. Well, the one obvious question that I wanted to ask is the price or the cost of treating the same disease going up at rates that are far beyond the inflation rate? But maybe we'll answer that after the break. Okay, now that we have some basic understanding of the drivers of healthcare costs, how best can we address this problem? Let's find out after this short commercial break. Please stay with us.
Mourning is when different people take different directions to different places for different reasons to do different things. Streets come alive. Evening is when people go home to their loved ones and turn to South Africa's most watched and trusted evening news. Because we keep the nation fully informed. We are SABC News.
SABC News seeks to be the biggest, the most extensive and diverse news organization on the continent. Our mission is to provide accurate and credible news and current affairs programming throughout the day. We are committed to covering every part of the continent. We reflect the world to Africa and Africa to the world. SABC News, Africa's news leader. Now available throughout the continent.
Welcome back. It shouldn't be difficult to imagine that the ideal of achieving universal healthcare coverage that is equitable, affordable, and quality healthcare for all can be easily derailed by crippling healthcare costs. It is often said that healthcare costs can be managed by either controlling the demand and or supply side, as was discussed earlier. But is it that simple? How can we achieve cost-effective, accessible, and affordable healthcare for all without compromising on quality? Let's find out from our guests. Dr. Bomela, now we've understood now, obviously there's not enough time to discuss everything, but we have some basic understanding of what drives healthcare costs. Let's talk solutions now. What can we do? Perhaps from your perspective, what would be the role of the service providers like yourselves?
So you stopped the last session with a question.
Yeah.
And the question you asked was trying to get a sense of whether it is just the demand or it is the real cost of providing the care.
Yeah.
I might just share with the viewers that if we look at price inflation, 2010, 2011, 2012, as published by Stats SA in the private hospital environment, the annual year-on-year inflation for 2010 was 6.9%. For the following year, it was 5.7%. And then in 2012, it was 5.1%. Now, the cost of healthcare, the inflation, if you look at the overall cost, was about 4%, going on to 5% more than that.
Above, yeah, okay.
Which then tells us that there is something that the service providers are doing in their operations to try and manage and control what is under their control. Because during this time that the price inflation is actually flattening like this, which I've just described, the cost of labor, as in nurses' salary, the cost of electricity, and other input costs within the hospital environment was way above inflation. So the hospitals, the private hospitals, have actually responded naturally by doing what they can to control within their business operations what they can control and contain the costs.
Let me ask Dr. Basha, can the hospitals do more?
I think they can. I think we would like to see from the hospitals, and certainly if we get a lot more lives in the market, if we can get some more, particularly in the low-income area, there's work going on in that at the moment. If we could get 5 or 6 more million lives in the hospitals, in the market, we would love to be able to see what innovations that the hospitals can come up with to be able to serve them in a different model. Because I think the current model is directed at a certain level. But I mean, if you look at countries like India, for example, they're able to come up with innovations that can provide hospitals and services at a much lower cost. And so I'm hoping that we will have a market to be able to do that in this country, and that the hospitals will be able to respond to that and look at different models. The other thing we need to look at is, for example, surgical procedures. 70% of them could actually be done outside of a big hospital. We'd like to be able to see more kind of day hospital facilities, to be able to direct our patients, more to those kind of facilities where the cost base isn't as high, and we could perhaps get things done at a lower cost. So certainly I think there's a lot of room for innovation in that space, as there are in many other spaces in healthcare.
All right. Let's get a view from Prof. Chetty from our Devon studio. Prof. Chetty, your views, please, in terms of what can be done and perhaps the role of medical professionals in trying to get the costs a little lower without necessarily compromising on quality.
Yeah, I think the medical professionals have a very positive role to play because it's them that makes the decision that causes the healthcare cost to go up. So I think if I talk to you from the perspective of the IPA Foundation of South Africa, what we're promoting is a concept of best practice initiatives, where the doctors have been told, we want you to provide the best outcomes, the best care the patient gets, at the least expensive, make it most cost effective. But we also, the caveat to all this is that it mustn't compromise quality. And what we find that if we remove just one thing, and that's the waste in healthcare, and the waste that I will define here is what's causing cost to go up, is the duplication of services, the unnecessary services, the fact that we are not working in a coordinated fashion between primary care, secondary care, and tertiary care. That needs to be sorted out in terms of a more coordinated, collaborative way. And I think the important thing that we've already subjected ourselves to a process of a thing called profiling, where doctors' work on a day-to-day basis is profiled and categorized in terms of cost, which is a small component now, and in terms of quality, which is a huge component. And then to bring this to fruition and to get a positive outcome, we are now having a process around the country called peer mentoring, where providers are brought together and we talk through the process of how we can still remove unnecessary costs, make the costs beneficial, make the outcomes good to the patient, and we're actually starting to reward doctors. And I think this is showing benefit from what I've seen on the results of numerous of peer profiling processes. The costs have been dropping marginally, but it's already started. And we're seeing, as Bomela said, the hospitals may be doing it, and Mike said it's happening with the other disciplines. Certainly in the primary care discipline, we're actually seeing a drop in unnecessary and expensive care, and we're seeing more positive value-based outcomes. And I think that's going to be very positive for the future of the private sector. The last thing I would like to say is I think government must step in at this stage like they did in the Netherlands and the rest of the world, and they must legislate the private sector in a very responsible and positive way. And I think it's time that we all sat down and found a public-private solution to the high healthcare costs. And just three things. I think sitting in the private sector is a huge HR management expertise, facility management, financial management, technological management. And I think if we have some sort of relationship, both sectors can start using the resources and the expertise of each sector and find a solution. But I think no sector is going to do this alone if we continue in the silos that is so predominant since 1994.
Very profound. Now, Dr. Marshall, he mentioned, the work that medical professionals are doing on their own, but surely they need support. What role can medical schemes play in that regard?
Yeah. We spoke earlier about managed care, and if you look at what's happened in the private funding industry, I mean, it initially started where medical funds paid collected contributions and paid claims. Costs went up, managed care came in. Now, that was a very transactional type of intervention. There was rules-based, we pay for this, we don't pay for that, you can only stay so long in hospital. And that had an impact, but I think a limited impact. And when you hear the challenges that are happening now, and particularly the rising burden of disease, the funders, I think, have a very key role to play in that. And I think what I think a lot of funders are looking at now is they've sort of coined the term population health. And I think there's a couple of key areas around this in terms of where managing costs is going to go. The first component of that is actually empowering the patient, the member. And I think we're all aware of the plethora of technology and apps and all that's coming out, and patient portals, and I think that's key. Trying to help members to accept responsibility for their illnesses, and I think that the funders have a key role in that. The second component of that is moving from what has been a reactive type of model of managing costs to a predictive type of model. So because we have this huge mine of data, and the coding in our private sector is actually relatively good, we're able to actually identify upfront, proactively, who are the patients that are sick and that are going to drive costs. And that's really key, and that's actually how medicine's going. It's predictive, it's genetics. Now, if you know who those are, you can actually do something.
Okay. It looks like we're going to need 2-3 hours because there's just never enough time to tackle all of these things. But unfortunately, I wanted to give you the last word, but unfortunately we've run out of time. Dr. Bomela, Dr. Marshall and Prof. Chetty, thank you so much for your contribution. It's on that note, folks, that we come to the end of our show today. Your views and comments are extremely valuable to us as always. Please share these with us on Facebook by going to SABC Health Talk and like our page. You can follow us again on Twitter at SABC Health Talk, or just drop us an email at healthtalk@sabc.co.za. So join us again next week on SABC News. And remember that you can watch the repeat of this show at 10 p.m. tonight. Or if you miss it, you can get it from the YouTube channel. So for myself, Dr. Sello Mutaung, and the rest of the crew here, it's a very warm goodbye, and please do take care. Sorry.